Okay, good morning, everyone, and welcome to our Tuesday morning grand rounds. It is my pleasure this morning to introduce two of our longtime faculty here. Due to a glitch in getting their bios, I'm not going to be able to tell you exactly where they went to medical school and all that stuff, but I'll ask each of them to just give a short introduction. But anyway, we have Dr. Rob Little, who's been at Phoenix Children's for over 20 years. In the PCH neurology department, and he specializes in both headaches and working with the neuro-oncology patients. And then Dr. John Curran has also been at Phoenix Children's probably almost as long. One of our first neuroradiologists here. Were you the first?
No, Dr. Miller.
Okay. But shortly after, I think Dr. Miller got here, Dr. Curran came here. And so back in the day, we did not have neuroradiologists. So he was one of the first. And their topic this morning is imaging and the diagnosis of headaches.
Thank you, Dr. Curran. Good morning. So I want to say there's a fair amount of content in this, but this is, as you know, the PCH grand rounds are now up on YouTube. So I wouldn't worry too much about if you miss something or you find our slides too cluttered with anything. Just go to YouTube in a week or two and you can look at it in your leisure, look up some point that you need to cover. As mentioned by Dr. Hartley in his kind introduction, our talk this morning is imaging and the diagnosis of headache. And I want to point out that while it would be a privilege to belong to the neurology department, we did have a problem with the slides and it shifted neurology from Rob over to under me, but he's neurology, I'm neuroradiology. But I'm just mentioning that in case some of the slides look a little funny. We're not able to control that. How do I click this? Oh no, I clicked down here. Yeah, sorry. Okay, so our learning objectives today are.
It went. It's no longer on the side screen, so. There we go. Okay, now it's up.
Our learning objectives today will be understanding the indications for imaging and headache and recognize common imaging findings in secondary headache and identify inappropriate studies in specific headache situations. And I'll just say, and both of us will repeat this, the idea is basically if you consider the patient to have a primary headache, there are really only very limited indications for imaging. But secondary headaches most likely will involve imaging.
Right, so we want to look at this both from an imaging standpoint as well as from a clinical standpoint. So if we're looking at this clinically, we want to talk about primary versus secondary headaches. Within the field of pediatrics, if you're looking at primary headache disorders, migraine is by far the most common thing that you're going to see. Tension type headache may be a little bit more common in the overall pediatric population, but because those headaches are often mild, they don't always come to attention of medical professionals. So if you look within clinic, either a general pediatric clinic or even a headache clinic, migraine is by far the most common primary headache disorder that you're going to see. Of the other ones, things like cluster headaches, the other trigeminal autonomic cephalalgias, primary stabbing headaches, those are not unheard of, but those are very, very rare. So you will not see those as often. In terms of secondary headaches, the things that we're going to talk about today are going to be ones that primarily show up on imaging. So things that can cause increased intracranial pressure, such as tumor, what used to be called pseudotumor, now idiopathic intracranial hypertension, things that cause decreased intracranial pressure, such as spontaneous intracranial hypotension. Chiari malformation is a rare cause of headaches, but we're going to talk about that because that's something you see on imaging a lot. And then we're not going to touch as much on things like infection. The other thing that is a big cause of secondary headache that we will not be talking about today is concussion and post-concussion headaches. And the reason why we're going to not talk about that today is because that doesn't really show up on imaging, not something that is an indication always for imaging. But this is a partial list. This is not every primary or secondary headache that we know of that has been described. If you want to see every single primary and secondary headache that's been described, go to the International Classification of Headache Disorders, published by the International Headache Society. It's currently in its 3rd edition. It's available at ICHD-3.org, and that has all of the diagnostic criteria for all of the headaches that have been characterized. And so when we're diagnosing a primary headache disorder, such as migraine, these are the criteria that we use. And so at your leisure, you can go look at that and look at that entire list if you're ever curious about the specific diagnostic criteria, but it's beyond the scope of this talk to go through the criteria for every, excuse me, for every single headache disorder. And then this is just a screenshot from the ICHD3. Again, you can go there and that will allow you to look at the specific diagnostic criteria for all the primary and secondary headaches. So in terms of evaluation for secondary headaches, and I'm going to say this a lot because I think that this is important, but history and physical examination is the most important part of evaluation of headaches and evaluation for secondary headaches. The history and physical alone is usually sufficient to diagnose primary headache disorders and to rule out secondary headaches. If there is concern for secondary headache, your history and physical can help you to determine what workup is necessary, because there are a number of things that you can potentially do to work up the headache, different types of imaging, a lot of things that you can do. And you can't do all of those tests for every single person with headache. And so if you want to narrow down, well, what is the most appropriate workup to do, your history and your exam is going to help to determine what that workup, if any, is going to be. So what are some of the elements of the history and physical that you want to pay attention to when you see a patient who has headaches? In terms of your history, you want to talk about onset of symptoms. When did the headaches start? If somebody comes in and they say, I've been having headaches for 4 years, I'm automatically much less concerned for a secondary headache than somebody who said, I have headaches that just started 4 weeks ago. So when did they have onset of symptoms? Some other characteristics of the headaches that you want to pay attention to: how frequently are they happening? How long do they last? The location, any sort of associated symptoms, whether that be migrainous symptoms such as vomiting, photophobia, phonophobia, or any other associated symptoms that would point you to some other disorder. We'll talk about some of the specific things in a minute. And then any change or progression in symptoms. Now, sometimes people who have migraine can progress from episodic migraine to chronic migraine. Frequency can vary. So a change or progression of symptoms doesn't automatically point you towards a secondary cause for headaches, but it's at least something that you want to think about. And so that's something that whenever I see anyone in clinic with headache, one of the questions that I always ask them is, have your headaches changed? Are there any new symptoms with your headaches recently? Anything different than before? And if the answer is yes, then you need to think about whether or not further workup would be necessary. Some things in the exam to pay attention to: obviously, you want to do a good neurologic exam. You want to pay special attention to the cranial nerves to evaluate for any posterior fossa abnormalities that would be of concern. You want to do a good head and neck exam. You want to palpate over the occipital nerve. You want to palpate over the forehead and over the supraorbital notch, over the sinuses. You want to make sure there's no evidence of temporomandibular joint dysfunction. Palpate for pericranial muscle tenderness if you suspect tension type headaches. So a good head and neck exam to help to rule out any other causes. And then probably the most important thing that you can do is a fundoscopic exam. If they have papilledema, that sends your workup in a completely different direction. And if they do not have papilledema, then that helps to rule out a number of secondary causes. In terms of what you do for workup for a secondary headache, again, history and physical alone is usually sufficient for the headache diagnosis, but when it's not, your history and physical is going to help to determine what you do. So what are some of the things that we do? EEG is not indicated in the workup of headache. And that sounds pretty obvious. That's a very old school thing that used to be done more commonly. And I was even going to cut that out from this talk because I thought, well, nobody does that anymore. And just last month, I got a referral from an outside provider who had done an EEG as part of the workup for the headache. So apparently it's still occasionally done, but there is clear evidence that it is not necessary. If you're only working up headaches, there is no role for EEG. If you're going to do imaging, the American Headache Society has published a position paper, which has also been endorsed by the American Academy of Neurology and the Child Neurology Society, stating that if you're going to do imaging, MRI is preferred over CT. MRI is going to give you a more detailed picture of the brain. It's going to show you more possible secondary causes for headaches. And CT obviously has radiation and has additional risks. And so there is no role for CT except in emergent situations, in trauma situations. There's no role for CT scan in the workup of headache. And then if you suspect either increased or decreased intracranial pressure or infection, then LP would be indicated. So what are some of the red flags? What are some of the things that if you see a patient in clinic and you're getting this history and physical, which is so important, what are some of the things that should worry you? In terms of your history, if you have sudden onset of headaches, again, abrupt onset, like I'd never had headaches before, and now I just started having a lot of headaches. Sometimes that can happen with migraine, but you at least want to think about secondary causes. Thunderclap headaches, which are headaches which by definition reach maximum intensity within 1 minute, is an absolute indication for further workup. So that is definitely something that requires workup. Same thing with new daily persistent headaches. That is an absolute requirement for workup for secondary causes. A new daily persistent headache is defined as a headache that is unremitting since onset. Patients can often tell you the exact day that the headache started, and it has not stopped since it started. There hasn't been a single moment that they haven't had a headache. Abrupt change in headache pattern, again, that's more of a relative indication, but if there is an abrupt change, you want to think about that. Positional headaches suggest a problem with intracranial pressure, either increased or decreased depending on the pattern. And then persistently focal headaches. Now, with migraine, a lot of times people will have focal headaches. By definition, migraine is unilateral, at least some of the time in adults. In pediatrics, it can be bilateral. But a lot of people will say, yeah, my migraines are kind of right here most of the time. But maybe some of the time they're on both sides, and some of the time it's my whole head, and that's okay. If it's 90% of the time it's here, that's fine. If somebody says, I have never in my entire life had a headache that wasn't right in this specific exact location, that's when you worry about some underlying space-occupying lesion, and that would be an indication for workup. And then in terms of your exam, any signs of increased intracranial pressure, such as papilledema or a cranial nerve 6 palsy, any signs of meningismus or fever, other systemic features, altered mental status, or any focal neurologic deficit, any of those things would be a red flag and would make you consider secondary causes. And for people who like mnemonics and acronyms, this is one that was published by Dr. David Dodick, who was the head of the headache program at Mayo Clinic Scottsdale for many years. And many years ago, he published this. And this is mostly in adults, but I think a lot of it applies to the pediatric population, but kind of in a different way, going over what I just went over in the last slide. So I'm not going to go over this entirely because I just said this, but if it helps you to remember it better, the SNOOPS, S is systemic, any sort of systemic symptoms, N is neurological, so any focal neurologic deficits, possibly by history, definitely by exam. Sudden onset, as I mentioned, the thunderclap headaches, either very old or very young onset. The exact ages for those cutoffs are a little bit debatable. We don't have to worry about the older age group in pediatrics, but in terms of younger, it's not an absolute cutoff under 5, but you at least think about it. Again, any change in the pattern of the headaches, headaches that are precipitated by Valsalva or cough. The presence of papilledema is an absolute indication for workup. Pregnancy, fortunately, we don't have to deal with that as often, but any new onset headache during pregnancy has to be worked up for secondary causes. And then any phenotype of rare headache, again, in the pediatric population, it's almost always going to be migraine or tension type headache. And so if there's some other phenotype, then you need to think about whether or not there are some other secondary causes.
Okay, so Rob's gone through the classification of headache and some of the red flags and so on. And we're going to deal with specific topics today. Chiari-1, migraine, SIH, that's spontaneous intracranial hypotension, and IIH, idiopathic intracranial hypertension. And finally, a word about headache and brain tumor. So Chiari-1 malformation is an isolated malformation of the posterior fossa, and the tonsils go down below the level of the foramen magnum. Here you can see the cerebellar tonsils abnormally low in position. And the classic findings in Chiari-1 are abnormal descent of the cerebellar tonsils greater than 5 millimeters, congested craniocervical junction, with often no CSF space at the craniocervical junction, and pointed tonsillar tips, the normal tonsillar tips being rounded. They may be less severely pointed, like peg-like, and also you may notice a vertical orientation of the cerebellar sulci. This next slide is just to distinguish the focal malformation, that is Chiari-1, just tonsillar descent, the rest of the brain is normal. From Chiari-2, people get confused between the two. Chiari-2 is a general brain malformation, and you have, for instance, in this particular case, dysgenesis of the corpus callosum. It's only a bit of it formed. There's a lipoma, the massa intermedia is enlarged, there's beaking of the tectum, there's a vertical orientation of the cerebellum. The fourth ventricle is elongated and displaced downwards. And so that's Chiari-2, not not a subject today, but as I said, that's just to distinguish KRE1 from KRE2. And, you know, you can see the descended tonsils on the coronal view, but also this is to show how we measure this. We're using the plane of the foramen magnum at the base of the skull, and then we drop a perpendicular down to the tip of the tonsil, and that's how we decide it's greater or less than 5 millimeters. Usually this is done in the midline. We identify the midline by the presence of the cerebral aqueduct on the sagittal view. As I mentioned, the tonsils greater than 5 millimeters below the plane of the foramen magnum measured in the midline. Usually it's best to do it in the midline because the base of the skull is actually sausage shaped. It's not flat. So if you go off midline, the foramen magnum may lift up slightly and you may be not able to get a consistent measurement from scan to scan. The tonsils are usually pointed, and effacement of the CSF, we mentioned bony features. This can be a related problem of a small posterior fossa or a short clivus, and the patient will need an MRI of the spine and spinal cord, because syringomyelia is also a feature associated with KRE1. And the percentage who have syringomyelia varies widely, but approximately, taking an average, maybe 50%. Hydrocephalus is rare. Hydrocephalus, however, it can be associated with KRE2. And here's the sort of simple mnemonic I need to remember that sort of thing. A KRE1 has one cavity and it's a syrinx. And a KRE2 has two cavities, the ventricles, and has hydrocephalus associated with. Sorry, there'll be we'll raise up the level of discussion from simple mnemonics. Finding of Chiari is an indication on MRI of the brain, is an indication to perform an entire spine. You can see that this kid not only has one syrinx here, but further down has a smaller syrinx. And the terminology, there's the term tonsillar ectopia. A lot of people treat it as equivalent to Chiari-1 malformation. The problem with that is if you label a kid with Chiari-1 malformation, suddenly, you know, at school, he's not able to play soccer because he's got a malformation and this sort of thing. I think personally, there's also the problem that in my previous associate in Chicago, the chief of neurology, was very strong in this. Don't call a Chiari-1 malformation unless you have a really solid Chiari malformation, because unfortunately there are people, mostly not pediatric neurosurgeons, who will leap in and do surgery for Chiari-1 malformation when really there aren't the symptoms or indeed the imaging findings to really justify that. So here's my personal way of describing things. Low-lying tonsils mean normal. If it's less than 5 millimeters, the tonsils are below the plane of the foramen magnum, but they're not down to the level we consider pathological. Tonsillar ectopia means down below 5 millimeters descent, but normal rounded contour of the tonsil, no crowding at the craniocervical junction, and CSF is visible before and aft of the craniocervical, the cord and so forth at the craniocervical junction. Chiari the Chiari malformation, greater than 5 millimeters descent, pointed peg-like tonsils, and a tight craniocervical junction.
Okay, so looking at this then from a clinical perspective, Chiari malformation is relatively common. It's observed on imaging in about 1 to 3% of MRIs, and it's usually seen as an incidental finding. A symptomatic Chiari is only about 1 in 100. So 99% of Chiari malformations that are seen on imaging are asymptomatic. And that's important to remember, because that means that if you see a Chiari malformation, it's unlikely that it's going to explain headaches or other symptoms. And it's not something that the presence of it in and of itself is an indication for referral for surgical decompression. As Dr. Curran mentioned, that's something that sometimes happens. I think that our neurosurgeons here do a very good job of evaluating Chiaris and determining when it's appropriate to decompress and when it's not. But unfortunately, that's not the case for everybody in the Valley. And so you need to be careful if you see one to not automatically assume that that's something that requires referral to neurosurgery or surgical decompression. So what are some of the features that would indicate that this is that 1% of the time when it is a symptomatic Chiari? Well, people will complain of posterior headaches and neck pain. So the headaches are exclusively posterior. If they say, well, sometimes it's my whole head, sometimes it's the back, sometimes at the front, or if they have typical migrainous features and frontal headaches, that is not consistent with a Chiari malformation. Exclusively posterior headaches with or without some neck pain and stiffness may be an indication of a symptomatic Chiari. The headache can be induced by cough or Valsalva. That is a feature that if you do get that, that might be a little bit more worrisome that you do have a symptomatic Chiari. And then sometimes they will also have other chronic symptoms of lower cranial nerve dysfunction. So chronic dysphagia without any clear explanation, or chronic respiratory problems, chronic cough, that there's no other clear reason for that. Those would be indications of a symptomatic Chiari.
Our next topic is migraine. And I would just start off by saying there's basically no necessity to do neuroimaging in patients with headaches consistent with migraine who have a normal neurologic examination and there are no atypical features or alarm signals present. And this is from the American College of Radiology appropriate criteria. It's openly available on the web. And if you're thinking about imaging and you're not sure whether imaging is appropriate, you can simply go to it, and they have multiple categories in each group. This is the category for, basically primary type headache. And you can see that usually not appropriate is the description for all of the possible imaging listed on the left. Again, acr.org if you want to look at that. And the criteria for ordering an MRI, and Rob will also go over this, neuroimaging may be performed for presumed migraine for the following reasons, prolonged, persistent course, aura, or prolonged or persistent aura, increasing frequency, severity, or change, first or worst migraine ever, migraine with brainstem aura, migraine with contusion by brainstem with motor manifestations, hemiplegic migraine, late life migraine, aura without headache, side locked, unilateral always headache, and post-traumatic headache. Now, still, if the migraine is classic and there's no other stuff, there's no other neurological findings or alarm signals, imaging is not indicated. Now, patients do get MRIs, and one problem that turns up is migraine spots. And I'm going to we had a little problem with the slides, the size of them, and they've been sort of changed a little bit. And so I need to put on my glasses to actually read them. So MRI is normal in hemiplegic migraine. Venous dilation can be seen on susceptibility weighted images, contralateral to the hemiparesis, although this is not typical. Changes in cerebral perfusion have also been described, and we'll come back to that. And MRI may demonstrate T2 hyperintensities in the white matter of the centrum semiovale, and they're not dissimilar to small vessel deep white matter ischemic changes. These are distinguished predominantly on history, although a recent T workup suggests that there is increased T2 signal in the cortex overlying white matter abnormalities as well in the brainstem. There are a lot of reports about abnormalities in migraine on imaging, but they don't actually amount to something useful that we can use. For instance, this is from one of our radiology sources on the web called Radiopedia. And a large survey found that migraine with aura had these spots about 8% of the time. Migraine without aura had these spots about 2% of the time, and the controls had less than 1% of these. But even the most common or the most frequent occurrence of 8% is still a small group within the overall group of migraine. So, and once you even find that, you can't sort of say, oh, well, this is migraine because it's got migraine spots. There is a differential for them. It'd be manifestation of stroke, chronic small vessel deep white matter ischemic change, multiple sclerosis or other form of demyelination, and even a cerebral vasculitis. Just including that because the case comes up, the question comes up, what do we do about spots on some kid who's had an MRI for migraine? So this is a different thing. This is the perfusion abnormality that's in sort of sort of fairly new or fairly discussed at the moment. So we have a 13-year-old child who presented to our ED with headache, vomiting, and nausea. And the parents in the ED report the child was confused, had otherwise a negative neuro exam, negative CT twice for prior similar episodes. And by the way, it's not necessary to get a CT in every acute case. We do have the facility of a rapid MR. That's an MR where none of the sequences are longer than 30 seconds. And it's very useful because by and large, the kids don't need sedation and it's done very quickly. The whole scan takes a very short length of time. And so if you're worried about a mass in the brain, get a rapid MR. Do not do a CT because that's radiation. And you'll get a clearance that the kid does not have some serious, mass in his brain. Here's just to show that this is the T1 images from the T1 sequence are normal, and from the T2 and the flare on the bottom row, those are two sequences that we rely on particularly to show up masses and edema and so forth. But when we went to the ASL perfusion, a type of perfusion study that we do, you can see that actually this is portrayed opposite to what normally is because of the nature of the display. And the right hemisphere is well perfused. You can see good perfusion in the cortex, both medially and laterally. And then as we go up in the brain, we see that the posterior left hemisphere is severely underperfused. And this is a phenomenon termed cortical spreading depression. And cortical spreading depression, also called spreading depolarization, is a wave of electrophysiological hyperactivity followed by a wave of inhibition. And spreading depolarization, if discussed in isolation, can be termed a depolarization wave of neurons and neuroglia, which propagate across the cortex at 1.6 millimeters per second. We put in the velocity here because that's in terms of the brain, a very slow velocity. And I think Rob will also mention that velocities can vary in this thing. Here is a diagrammatic explanation of, or at least illustration of cortical spreading depression. So we have it back here starting in the occipital lobe, and then it gradually extends forward. Up here is the central lobule with the central sulcus, and you can see that it takes 16 minutes before this depolarization reaches the center, the middle of the brain, the central lobule, the central sulcus. And this is just a case report from 2020 from neurology. And here we have cortical spreading depression on the left, the hemisphere displayed on the left side of the brain. Don't see a marker, so I presume it is the left hemisphere. But there's an increased signal on the diffusion image and a little bit of hypo intensity on the ADC, suggesting that there's an element of possible ischemia in this condition.